you will find things like that. You will find the derivatives of mesoderm. And mesoderm is going to provide the connective tissue. It is also going to provide all of the cells that are associated with connective tissue. It will also provide other structures, because mesoderm, as you know, produces what is between the endoderm and the ectoderm, and that includes bone, muscle, a lot of stuff is produced in that area. Bone marrow, the cells that are coming from the bone marrow, all of them are derived from mesoderm. So it also includes packing material, and packing material you need so that things don't jam, and you can land easily. You know, when you have packing material, you don't get damaged. So even the bone itself needs to be protected. And so there is packing tissue, the soft tissue that surrounds it. The elements of the scalp are part of that packing tissue. Now, as we move from the connective tissue, what next we go to? Aponeurosis. Now, here it's a kind of glancing shot, a glancing cut, and this is at the top of the man's head. Alright, this is at the top of the calvarium. So what it means is that the muscle that is present, that is supposed to be underneath the connective tissue, what has happened to it here? Why is it that I'm not seeing it? Why I'm not seeing much of it? You can see a little brown, you know, a little brown, but it's not very prominent. And it is like this because at the back, the occiput, you have the occipitalis. At the front, you have the frontalis. So you have muscle at the front, muscle at the back, and between the two, you have varying amounts of muscle and also aponeurosis. So in a man of this age, he will have a fair amount of aponeurosis between the occipitalis and the frontalis. So when you take a glancing cut at the scalp, you are not seeing much in the way of muscle. What you'll be seeing is some of the aponeurosis. So that whitish kind of stuff that you see deep to the connective tissue, that you see on the edge, a little brown here, that is going to be representing the occipitofrontalis layer, or the aponeurotic layer. Deep to that, we will have the loose connective tissue, and that area is kind of loose when you take the cut in the scalp and you pull it across, pull it over there, and you can, as it were, descalp the person because you move into the loose connective tissue. What tell you one implication of this in terms of someone who gets hit on the head? One clinical significance of this loose connective tissue layer? Sorry? There's a potential space right for bleeding, and if you get hit in the head, then you can see sometimes in the morning, I give you patient about a half around the head. You might see in the morning that around the eye is swollen because that loose connective tissue layer, fluid traps inside it, blood, and once blood gets into it, what will happen? Once blood gets into this loose connective layer, what will it do? Blood has, what blood has in it? Blood has a lot of protein. And these proteins are going to exert what? An osmotic pressure, which is going to pull water into the area. So the area is going to swell, and it is loose, so the tissue the fluid can move in that loose connective tissue layer. So it comes below the eye easily, and you can see a swelling. Or you might even see that the conjunctiva looks red, bloodshot, because of the presence of fluid, a hematoma in that loose connective area. Deep to that loose connective tissue, what do we get? periosteum, and then we come on to bone. Now, if you look at the bone, you notice this outer layer. What do you call this outer layer? Compact bone, and this another name for it. Not dura. Another name for this top bone here. Petrous, no. Remember we are in the top, and the top part is the calvaria. Petrous is on the base. Petrous is on the base. Here is petrous. Shoot. Make it small. No, small. Come back. Like if you're looking from afar. Right, you see petrous is on the base. Once we are on the side, we are in calvaria territory. The calvaria, the upper part, the walls, are the calvaria. Down on the base, that's the floor. So basically, the skull has a floor or base, and the calvaria, which are the sides. Good. Also, we are seeing some of that here. The part of the calvaria, but it's the outer layer. What do you call that? The outer layer of the bone is called the outer plate. Outer plate. And this part inside here is the inner plate. And the place between the two is called the diplo. The diplo, right. So there is where we're going to find our marrow. And also, because it is very vascular, it means that cancer cells can come inside there easily. So patients who have sometimes cancer cells like myeloma, you know that? That disease, you ever heard of that disease? Myeloma. What are the cells that make proteins? Cells that make proteins, that make globulins. Those cells that make globulins are called plasma cells. So when you have a cancer that involves plasma cells, a plasmacytoma, multiple plasma cells, then that is referred to as a myeloma. And those diseases will make holes in the bone. You take an X-ray patient with multiple myeloma and you see whole heap of holes in the bone because they come inside here, they multiply inside the marrow, and then they invade the outer plate and inner plate, and you get translucency. So when you take an X-ray, you'll see holes in the bone. So you have an outer plate, inner plate, both of compact bone. And then internal to that inner plate, what do we have? What is this white thing I'm touching here? Dura. Good. So let's look at a deeper shot. Okay. I can compose. Right. So here we have the outer plate, diplo, inner plate, and then we have the dura. Good. And I was saying that usually we can get in very easily between the dura and the bone. Why? It's very adherent, and if you know, I can show you a specimen, I don't have it right now, but you can actually see like collagen fibers that are innervated in the bone. So the outer part of it is thick related. These fine fibers of collagen are inserted into the bone, and they hold the outer part of that dura tightly to the inner plate, to this inner plate. Deep to that, we were saying that the brain itself is pretty soft, as you can see here, pretty soft, and so it needs covering, which covering is called a pad of Meninges. The inner layer that goes in all the nooks and crannies of the brain, that layer is referred to as the pia mater. So we have the pia, which is going into all the little roots, and we have stuff like this, which does not go into the crannies. Instead, it jumps from hilltop to hilltop, and that is the arachnoid matter, right? Arachnoid, spider, and because it is jumping and it is making something that is web-like. If you look, I don't know if you can blow up this thing here, you can see a lot of spaces inside it, like cysts, like cavities. You see that? Yeah, man. Good. So it just shows you how there in the body there is no space, there is no air, there is no. When I'm not talking about the mouth and the stomach and the intestine, but move away from that into the tissue. There is no space. Everything is occupied. You understand? So even in the brain, where you have fluid and you have meninges, all underneath the meninges, all under, between the dura and the arachnoid. Between the dura here and the arachnoid, there is no space as what you're seeing here. Huh? This is you call this is subdural space. Look at it where I am. No, if you think I should call it subdural, then you have to stick to your guns. Is it subdural or is it not? Huh? Suppose I say it is extradural. Suppose I say it is epidural. Huh? Suppose I say it is epidural. Is it right? Don't give me another answer. Is it right or is it wrong? Epidural. No man. Is it right? Is it wrong? Epidural. Wrong. Why? Because I am under the dura. I'm inside the skull. I'm under the dura, so I have to be subdural. If I'm outside, then I'm going to be upon, and that is epidural. So out here is going to be epidural. So if I have a blood clot outside here, that's epidural. But if I have a blood clot underneath here, that's subdural. Good. No, but the point I'm making is that between the two, there is normally no space. So what happens is that the two layers are adherent. They only move apart if something like blood or something gets inside there. Alright? Otherwise, they are close together. There is no air between them. You notice that the layers are smooth? The layers are smooth. So what kind of surface would they be having? What kind of epithelium would I be finding here? Simple squamous. Okay. Now, good. So then we have here the dura. Outside of it is epidural. Inside here is going to be subdural, and here is the arachnoid. So what is inside here? Subarachnoid. Why is it that the subarachnoid has all these little things inside, these little cavities? What do you call these areas that form the compartment, the space for it? The tissue that I'm actually moving, what are they called? No man, these things that I'm touching like this, why is this? Arachnoid granulations, no. Look at these man. When I squeeze them through, it comes up, eh? What are they? Huh? Trabeculae. Trabeculae within the subarachnoid space. So this is the arachnoid and these are trabeculae within the subarachnoid space. Why do you need that? Why do you need that? Why do we need that? But won't it flow without that? If they want that, yes, that will still flow. Why do you need to increase the surface area inside there? Huh? I wouldn't put that as a strong point. But let us say a sound wave was supposed to go through the skull. What do you think that all those trabeculae will do? They will function like baffles. Baffles. Yeah, baffles mean it will help in preventing excess. It will help in keeping the environment less boisterous. It will be quieter. Because you see, all these will function like little protectors for the sound waves so that it protects the brain. Yeah, so they function like baffles. The other thing is that on a bigger scale, this valve that is in the middle is also functioning as a baffle. Because if you get a box on your chin, absolute. If you get a box on your chin, what will happen? Your face is going to spin. Right, what do you think will happen to your brain if you didn't have any baffles inside here? It will spin too. Right. So to cut down on all of that, then we have all these baffles on the inside. So we have the big baffles, and then we have the little baffles. And that is what those these trabeculae within the subarachnoid space help in doing. Alright. Okay, so we go from the subarachnoid space and we get to the tire. And the tire, as you know, goes and covers faithfully every little nook and cranny that there is there. Alright, now what is this in the middle here? What is this? Okay. Alright. Now, now here we have the brain, and pretty big. You notice how the brain looks? One side is flat. This brain has had a hard time, This brain has had a hard time because this brain was not in a protected layer. It was not in a protected box. Look at it. One side is pressed down and the other side is pushed out. Now, that will happen in our brain, in our box, in the skull, because the box will protect it so that there will be uniformity of pressure on all sides of the brain, so that you have been keeping this kind of ovoid or ellipsoid shape. Alright? The other thing is that the box itself, the weight of this brain, is in the vicinity of 1.35, 1.45 kilograms. Alright? 1.35 in a woman, but 1.45 and more in a man. Alright? Does it mean that the man is brighter? Okay? But the weight of the brain on this plastic thing that I have here is a problem. If the brain were resting on the skull like this, we would be dead. Why? It will be compressing all of them gray matter underneath. So why does not in the skull? The CSF within exerts an obstrust. Archimedes principle. What that says again?
Anyway, the obstrust is the fluid.
Body what?
Why the ship?
While it's free, the floor, equal to the weight of the contract.
Oh, it looks as if some of this kid is when has gone. Has gone. So what is the how you calculate the uptrust? Different in height.
So like some physics no.
Something as the heel in the back here. Alright, the uptrust is equal to the volume displaced multiplied by the density of the fluid. The density of the fluid that the thing is submerged in. So in other words, the uptrust in seawater is going to be bigger than the uptrust in fresh water. So you might have a hard time in fresh water, but you're easier for you in salt water because the density is higher. The volume, same volume of person in both settings. And that again is going to tell you why both are going to become higher and they move from getting to seawater as opposed to being salt water, which means that the thin salt lines will be into the chain. That takes me back to long years ago. Alright, now, so we have a brain in fluid and therefore its effective weight is only 2 ounces. In the CSF, cerebrospinal fluid, the weight of the brain is only 2 ounces. So 1350 grams, 1450, 1550 in air, but when submerged in the box, it only weighs 50 grams. And therefore, the pressure on the underside is now much less, and so we don't have any damage. So you can sit down and listen to have a discussion. Alright? Now, the surface, as you notice, is covered, arachnoid covers it. And in the center, there is a partition that separates right side, left side from right side. Okay? And you know that partition is formed by the phalanx cerebral. Right? There's also a smaller partition between the cerebellum and what we call that partition, the phalanx cerebelli. And between the two there's a horizontal partition, and that horizontal partition is referred to as the tentorium cerebelli, and the space is referred to as the which fissure? The transverse fissure. So we have a transverse fissure here going from side to side, and we have a central longitudinal interhemispheric fissure. Interhemispheric right left hemisphere. Alright? Now if we were to cut right down the center, then we will be able to get something that looks more like this. So we'll be talking about this half, take a half. Alright. Now the parts of the brain, or the lobes of the cerebrum, are kind of named after the places where they are. So we have frontal bone. So the lobe that is beside the frontal bone is the frontal lobe. We have temporal lobe. And so temporal lobe is sitting beside the temporal bone. In the back, we have the occiput. So the lobe inside here is going to be, towards the back, is going to be occipital. Bear in mind though that the cerebellum is sitting right down in the posterior cranial fossa. And it is the tentorium that is attached along its roof. And sitting on that is the occipital lobe. Occipital lobe. Alright, and then on the side, not to be outdone, we have a parietal bone. So the part of it that is under and opposed to the parietal bone is the parietal lobe. So roughly, when we think about the outer surfaces, we could name them according to the particular bones that they are associated with. On the medial side, there is also another lobe here. And this lobe is referred to as the limbic lobe. The limbic lobe. So this arm is made up of this amount of tissue that is right here, this gyrus. We'll come back to it. But so we have that, and over on the lateral side, if you look at this specimen has been, a piece of it has been removed. Right. And if you look underneath here, you see some convolutions, some sulci, and some gyri. And that represents a lobe that is buried. And this lobe that is buried is called the insula, or island of Rand. Alright, so that makes six lobes now. So we have the frontal, the parietal, temporal, the occipital. On the medial side, we have the limbic lobe, and buried in the lateral, superolateral, we have the insula. Okay. Alright. Now, somewhere around 1641, there was a man, people have always been interested in the brain, and he got a brain and started studying it, and realized that this section that is here, which is a fissure, actually starts on the front and then goes laterally. And so this fissure, lateral fissure, has been named after him. So we call it the fissure of Sylvius. Right. And then almost 101 years later, another fellow was born, and he started looking at the brain as well. And he found out, well, this one on the side is kind of obvious, but if you look here, there seems to be a partition here between front and back. And he was a very keen person, and he used a microscope and studied the brain. He also used the microscope and looked at the spinal cord. And he found that there are some people who have epilepsy, and the epilepsy affects activities related to motion and related to sensation. And so we have what is referred to as the fissure of Rolando. Rolando was a rolling fellow. So he didn't only stay up in the brain, he also rolled onto the spinal cord. So we have the substantia gelatinosa of Rolando. You have all of the substantia gelatinosa when you're doing your upper tracts, pain fibers, right? So that as well is named after Rolando. And then we have epilepsy, seizures that are based on Rolando, because he found out that there are some people who have seizures related to this junction between the frontal and the parietal part of the brain. So we talk about Rolandic seizures. Alright, well, let us just look a little at some of these lobes. We do have a frontal lobe, frontal at the front, and the end of the frontal lobe is referred to as the frontal pole. So we have a frontal pole, and we have an occipital pole. And this occipital pole is going to be beside the inion, and the frontal pole will be close to the nasion. Nasion, right. And if we were to measure the distance between the two, we might find that the junction between the frontal and the parietal lobe is not exactly in the midline, but a little behind the midline. Okay? Now, the frontal lobe has, okay, when looking at the brain, basically all these thin and bodies, what do you call these depressions? Sulci, sulcus, one sulcus, more than one sulci, and what we call the elevation? Gyri, gyrus, gyri, singular plural. Now, so this one here is going to be the superior frontal gyrus. This one here is going to be the middle frontal gyrus. And this one here is going to be the inferior frontal gyrus. Good. Now, if we look on the, well, in terms of surfaces, we can say that this surface is the superolateral surface. And the superolateral surface is convex. Superolateral surface is convex. The medial surface is flat, and the inferior or basal surface is irregular. Irregular because the frontal section is concave, and the temporal or temporo-occipital part of it is concave, part of it is convex. Sorry, part of it, this back part is concave, and this part, the temporal part is convex. Alright? So the base of the skull, sorry, the base of the brain is irregular. It has an irregular surface. And that coincides very much with the base of the floor, with the floor of the brain, because look, the anterior cranial cavity is pretty high compared with the middle. You have a step down. You're going down from 1, you step down to 2, you step down to 3. So you kind of have a depression in terms of the base. Yeah. Alright. Okay, a little bit more on this superolateral surface. Right. Now, when you look at the superolateral surface, look at it. There is a sulcus that is running this way. There's another one running up here, and there's another one running this way. So we call this one here the horizontal anterior sulcus. This is the ascending sulcus, and this is the posterior sulcus. Okay, and these are all related to the inferior frontal gyrus. Right, so the inferior frontal gyrus has an horizontal anterior, and ascending, and a posterior sulcus. Right, and this area represents the pars orbitalis, pars triangularis, and pars opercularis. Opercularis is operculum. It's something like a cover. Right, what the fissure. So when this operculum, when we lift it up here, then we see something underneath. Are you with me? When you look inside there, you see something? You see some buried cortex inside there. You see that? Right, so these are rightly named when you refer to them as operculum. opercular. But the area right here is important clinically and is referred to as Broca's area. Broca's area, and that has to do with motor speech. Speech, or is going to involve hearing something and saying something proper. So if I'm not hearing you right, I say, but I'm saying exactly what you are telling me to say. Okay? Because I am not able to process what you are telling me. It's not just saying because that's not speech. I need to be able to hear what you say, understand what you say, and repeat what you said. So we have receptive aphasia. Receptive means I have to receive. And then we have output aphasia, motor aphasia. Are you with me? Right. So the problem could be at either end. Yeah. The area, the three little areas would be these areas. And they are related to the presence of the sulci. So we have the horizontal anterior sulcus. Then we have a ascending, and we have a posterior, right? So that is going to give rise to these little projections here, which are referred to as part of the operculum. So we can have a pars orbitalis because it's related to the orbit, pars triangularis because it might look like a little triangle, and pars opercularis because they function like columns. Yeah. We won't bother you with these pars orbitalis, and we have more important things to ask. Yeah. So even if you don't remember the pars, that's okay. Pars just mean portion of part of pars. Yeah. More important, if you remember that the area is Broca's area, and it is related to the anterior part of the temporal lobe on the frontal side. In other words, the inferior frontal gyrus, yeah, has Broca's area on it, yeah. And the speech can be affected if the blood supply to this area is impaired. If someone has a stroke and they can say something, then you know that this side of the brain is affected by the stroke process. Right? Or somebody gets hit, or if look at this. Look at this. When I put this inside here, the brain inside here, one of the real reasons for the lateral sulcus is because I have here a fissure. I have this in here, a bone which is projecting between the frontal and the temporal lobe. Alright? Frontal lobe is here, temporal lobe is here, and between the two I have this wing of the sphenoid. It is the wing of the sphenoid that is pressing in on the side of the brain that helps in forming that lateral sulcus or lateral fissure. You follow me? So, if there is a blood clot, because look here, where I am here is very in the vicinity of the pterium. If there, and you know this, the middle meningeal artery goes up right here. So if there is rupture of the artery and I have a hematoma inside here, then that will press on Broca's area and will cause some trouble. Alright? So if I find that the man got hit in the head, he got hit with a cricket ball, and when you say, what's your name? Or pinch me, he's able to do something. He can't say anything. Then I would realize that this is not something to play around with. He needs to be taken to the hospital quickly. And if you are the doctor that is there, what are you going to do? you're going to consider that he's going to need to have a blood hole so that we can drain out the hematoma, the blood clot that is present on broken area. Right? But there are other people who get disease of broken area and it's not related to trauma. And it might be more related to having problems with the amount of patties that they are being eaten. Because that's the commonest food combined. Fatty food. And so cholesterol and oil is used. Alright. Now on the inferior part we have the temporal lobe. And the temporal lobe has a superior, middle, and inferior what? Gyrus. So a superior temporal gyrus, a middle temporal gyrus, and an inferior temporal gyrus. Okay? Now, when you look at the temporal lobe, what kind of partition would be used for the temporal lobe? Here's the temporal lobe. Here's the temporal lobe. So what are the boundaries? Is the superior, middle, and inferior temporal gyrus? What are the boundaries? Why do you call this place right here? This area right here is referred to as the pre-occipital notch. So that is used as your posterior landmark, and then on the medial side, on the medial side, yeah, good. On the medial side, we have this fissure, which is the parietal occipital fissure or parietal occipital sulcus. Right, so that is a line that is joining that sulcus to the pre-occipital area is going to represent the posterior border for the temporal lobe. Alright? Now, the temporal lobe, we said that the pre-occipital notch, this groove here, this little depression that you see here, that's the pre-occipital notch. And over on the medial side, so on the lateral side, you have this notch, pre-occipital notch. And over on the medial side, we have the parietal occipital sulcus. Right, so behind that is going to be occipital area. And anterior to that is going to be temporal area. Right? Now, a little bit more on this temporal area. We said that you see as you go up into this fissure, the lateral fissure of Rolando, you end up meeting a gyrus which is close to the central sulcus. See here is the central sulcus. Okay? But it never goes into the lateral. You get that? When I come across, I come at the end of a gyrus, but I can't get over it. It's not a sulcus, so I'm not leading into the lateral. You get me? Good. Now, this superior temporal lobe, what does it deal with? The anterior part of it. The anterior part of it deals with audition. The anterior part of it deals with audition, song. So, if the temporal lobe is not working well, then regardless of how high you turn up the music, he's not going to appreciate too much what is going on. Because sometimes when you pass these sound systems and you hear it turned up so loud, and it is almost as if it is vibrating within your lungs, then you wonder what has gone wrong. You know, whether this man has to hear to his bottom. Because it's turned up so loud and it is as if he can't hear. Or sometimes there is damage done to the receptors in the air, so these people, they are kind of dead. They're not sometimes working. Alright, now the anterior part of it deals with sound, and the posterior part of it deals with what? Language. Posterior part of it. So the posterior part of the superior temporal lobe is going to deal with language. We talked just now about hearing something and being able to repeat it. So this area down here refers to Wernicke's area, and that has to do with receptive aphasia. So if the Wernicke section is not working well, I can't receive what is saying. I can't interpret it, I can't process, I can't understand it. You're talking, but it's like you're talking Chinese. I can't process what you're saying. You get me? Right. So there's receptive aphasia. This is the part that is not working right. Okay. So we did the frontal and we did the temporal. And let us look a little bit at the central, Rolando's area. Now, look at the superior frontal. It's coming, running at the door in here. You can see that they're pretty short. Here's the middle. But this one here is definitely running transversely, and it's pretty long. And this one in front here belongs to the frontal, and this one behind here, piece of it as well belongs to the frontal lobe, and some of it belongs to the parietal section. All right, so it's not strictly a division that this right here is frontal, because you remember I did say that if you had the ilium at the back and the nasal at the front, and you took a straight edge and you went middle between the nasal and the ilium, you would the territory that you will be in for the receptive area is going to be behind about 2 centimeters or so behind the midpoint. Okay? So it's in that vicinity that we will find the central fissure. And the central fissure is moving at about 70 degrees, making about a 70-degree angle with the median. Okay? Yeah, don't worry about that. That's more like taking it to a third of it is taking a precision that is not born out in practice. Yeah, so it's roughly 70 degrees to the midline. Right? And if you were to, so the front sulcus or the front of gyrus, we will call that the precentral, and the one behind is going to be the postcentral, and they are going to meet in the center. Right, so this is going to be your central sulcus. And the anterior is kind of motor, dealing with a lot of motor stuff, and the posterior is sensory. Right. So the sensory area is going to be the postcentral gyrus, and the precentral gyrus is going to be your motor area. Right. Now, the medial part of that motor area has to do with what? Medial part. Well, what is usually done is to remember that there is a little man lying on top here. a little man lying down on here. So we refer to him as a homunculus. Homon, like man homo, and culus means little. So it's like a little man that is lying down on top there. And he has his buttock down here, and his feet hanging over here. His head and his tongue and his face are over on the side over here. So that's his rough position. It means therefore that if there's something wrong on the medial side, then the areas down the center, and this area is going to deal with things like defecation and urination. So the lower part, the genital area, is going to be affected by disease affecting the medial part of the sulcus. Whereas on the lateral side, if you look at the homunculus, you will see that his tongue is very big and the hand itself is very big, and that has to do with the kind of density, nerve density in these structures. Your hand, you can run up on the piano and you can play, do all kinds of things with the hand. And because the precision that is built into it, all of that is controlled by the lateral part of this fissure. Alright, now the parietal lobe is posterior to the frontal lobe. And if you were to look at the post-central gyrus, there is a line going down from it posteriorly, and that is almost like an interparietal fissure, interparietal sulcus. So that is going to give us medially a superior parietal and laterally an inferior parietal sulcus. And the parietal lobe deals with processing a lot of what is in our environment. So let us say that my parietal lobe was not working, and you gave me a ball, tennis ball or even a cricket ball, and you asked me to tell you what I gave you. I would have problems interpreting the texture, and don't bother to ask me about the weight, because I won't be able to tell you how heavy it is. I won't be able to tell you whether it feels soft, whether it's smooth, whether it feels warm, whether it feels cold, because all that processing power is coming from the parietal lobe. Stereognosis, position, sense, proprioception, all of that kind of information has to be processed by the parietal lobe. And I saw a patient just yesterday, and he has other issues, but his wife was saying, he behaves as if the hand is not his. He has it out and he moves, and he might even bounce on her, but he seems as it were not to recognize that he has, I think it's the left side, that he has a left hand. You laugh at these things, but when you really have to engage with someone who has these deficits, you begin to realize how blessed you are. So, yes. So this interparietal sulcus is almost like a straight line coming down. It's not really straight. It's kind of nothing in the brain is straight. Kind of ziggy. Huh? So it is kind of coming down here, and this is it right here that you see. So this part is going to be superior, and this is going to be inferior. And then the inferior part now, if you follow the lateral sulcus, then you can end up it's as if you come to this Y here. So you can go up top here or you can go down here. If you go up top here, then you get to the supramarginal gyrus, and if you come down here, you get to the close to the angular. Right. So these are kind of more related to the lateral section. Supraangular is going to be almost near to the parietal, the bosom or the parietal tubercle, where your parietal bone is widest at the middle. Alright. Now, what about this part behind here? What we call this area behind here? The occipital lobe, right? And it kind of looks almost like a wedge, almost like a wedge. And no wonder it's called this part here is called the cuneus. Cuneus. Cuneiform. You remember your medial and lateral cuneiform? Your medial and intermediate cuneiform? You don't remember?
Calva.
In the fourth?
Yeah, the occipital.
In the fourth man? Yeah, you mean. Yes, among your tarsal bones, your medial, intermediate, and your cuneiform. Oh, you see how this is big business, what it does to you? Very easy to fix. Yeah, cuneiform has to be cuneiform lateral. So if you look back on some Hebrew stuff, then you're going to find the cuneiform shape of the letters related to the kind of instrument they use for the writing. Alright, yeah. So this is going to be the cuneiform lobe. You know, it is cuneiform in terms of its shape, because it looks like a wedge, big above and small below. Yeah. And then the area in front of it is called the precuneus. The precuneus, right? And then just in front of the precuneus is a little bit of the parietal representation, right? So this will be representing the parietal lobe. So this is parietal, this is the parietal. And in front of here, most of it is going to be frontal. So frontal, little parietal, and behind occipital. Yeah. What's the name of this sulcus here? Parietal occipital. Very good. Now the parietal occipital sulcus is kind of deep, and so is this sulcus here. I already have an instrument I can put inside, but this sulcus here is a deep sulcus, and it is referred to as the calcarine sulcus. Some people might call it the post-calcarine sulcus. But it is so deep that it can be making an impression on the ventricle, posterior part of the lateral ventricle. And that projection is referred to as the calca ibis. Calca ibis. Ibis is related to what? Ibis is related to? birds, right? Calca,
No, baby and the
calca is what?
bird.
Alkawa?
Huh?
Alkawa?
Callus,
All right.
C-A-L-C-A.
You have a look close at the clothes for legs.
I'm so sorry.
How
And
many
in
toes?
trauma, depression, or
What is the above the toes?
Calca, Avis, or someone that is now I don't know.
You have clothes at home?
Callus?
Yes.
Callus?
Take a look at the head and look above the toes. You see a little index projection coming out.
Yeah.
That's a calca. Yeah, that's a calca. Calca Venus is a projection like a spur or you'll find on birds. So when you put going on top this depression makes an impression on in the lateral ventricle, and that projection inside there because as a calca Venus. Yeah.
Calca, Avis, or Calca, Avis, or something.
Now, you remember that this area behind there has to do with vision. Has to do with vision. So we have area 17 and area 18 and area 19. Probably at a later we can come back again to remind you about these things. But if you want to cut this cut the lobe across, then you'll find that there is a line on it. If you want to it's cut man. Because we will be doing the inside features at another date, and then I can just slice one freshly across, and then you can see the striped line of general. But you find it in the occipital area. You don't find it in other parts of the brain. Although the brain has all these sulci, and all of these projections. It is not uniform in terms of the histology. So you can, for example, like cerebellum, take a piece of cerebellum from the lingula and a piece of cerebellum from the pyramid. Alright. Yeah, take a piece of cerebellum from the pyramid or the uvula and you look at it under the microscope and it's very uniform. So you have your molecular layer, your pyramidal layer, your granular layer, beautiful. But when you take a piece of cerebrum and you take a piece of cerebrum from the motor cortex, a piece from the sensory cortex. Yes. Yeah. When you she was asking if we can save the content. So we are it's 15 tips, so 3 days. Are you with me? Yeah. So what I said, I got distracted there. All right. That when you look at different parts of the cortex, they look different. So for example, motor cortex is going to look different from occipital cortex. And for example, if I were to cut across the temporal lobe, the number of layers you'll find inside here is not the same as the number of layers you'll find on the cerebrum. The cerebrum proper will have about 6 layers, whereas for example, the hippocampus, I might only find about 3 layers inside it. You understand? So there are differences. It's not uniform like the cerebellum. All right. Any question? Insula, I showed you that. This one shows up pretty well inside, yeah? Insula. And this insula is formed as a result of the enlargement of the brain. The brain, the surface area of the brain is about how much? About how much is the surface area of the brain? About 2,200 centimeters, square centimeters. About 2,200 square centimeters. But in measuring, you won't get that. You will only get about a third of that. Because most of it is buried. Most of it is buried. The brain is about smooth until around the end of the first trimester. So past 12 weeks or up to 12 weeks, the brain is going to look pretty smooth. Lizard brain, fowl brain, going to look kind of smooth. But the brain of a man, brain of any of the people inside here, is not going to look smooth. It's going to be very convoluted with the sulci and the gyrus. And it means that in the second and the third trimester, there's so much growth of brain that the only way in which the body can accommodate all of this increased area is to keep burying the brain. So 2/3 of the brain is very buried. And what we are seeing on the surface is just about 1/3. Alright? And the insula shows very well the burying, because here is a whole lobe that is buried on the inside. It's thought that this insula might be a little more attached to the corpus striatum than usual, because it's close to the corpus striatum, and that as the Connective blows out and becomes more and more, the burying of the insula occurs so as to make space for this increase in size. So the 2,200 square centimeter total area now can become accommodated, and when you look at it, you just get about 1/3 of that in terms of the surface area. Yeah. They should also mention that in the central fissure, even within that central fissure, you again have a fair amount of folding in terms of the motor and the sensory plates. A lot of folding, motor is folding and the sensory is folding, and again that helps in creating more space on the inside. So it's not only a deepening of the layer, but also a folding as well occurring to give you that kind of wavy pattern that you get, as if there is some serration that is going on. Alright. Now, the other lobe that we haven't spoken about is the limbic lobe. And the limbic lobe is on the medial side of the brain. If we were to cut the brain in two, then what we'll have to do, we'll have to contend with this commissure that is present here, which is the corpus callosum. And there are sometimes, it's possible to find that there are some people who do not have a corpus callosum. Okay? It is referred to as agenesis. So one abnormality, if somebody put a pin inside this thing and ask what abnormality can affect this structure, and you see agenesis. Agenesis means no genesis, no formation. Then that is quite okay. That is an abnormality that can happen. And there are many people who are without a corpus callosum. Some of them have associations with chromosomal defects. One condition that can produce it is alcohol in pregnancy, in which you have hollow prosencephaly, in which there is a cavity on the inside, and that those people can have agenesis of the corpus callosum. So you might see it ACT, agenesis of the corpus callosum. Mental retardation as well is associated with it. But you could also have someone who has the incision, the thing transected, and they are okay, but they will have problems in terms of memory. It would be like they have two functioning brains, and memory will be disturbed. Alright. Now, if you were to cut through the corpus callosum, immediately underneath the corpus callosum, you will be coming on what? You'll be coming on in the midline. If you are flushing the midline, you'll be coming on the third ventricle. Right. But let me see. Okay, this is almost in the midline. Almost in the midline, but almost. What you notice here is that below the corpus callosum, there is something here. There's a septum. So whereas on this one I can see through. On this specimen, there is a septum here. That's referred to as the septum pellucidum. Septum pellucidum. And closely related to it here, we have a band, a set of fibers, which is the fornix. So if I were to cut right down the center, then that is going to get cut. The corpus callosum is going to get cut as well as the fornix. I can be cutting through the septum pellucidum, and I'll also be cutting through the third ventricle. Now at the top of right at the front of the third ventricle, anterior and the third ventricle, then I have a border here. And this border is the lamina terminalis. Lamina is the layer, terminalis is the end. So the end of my third ventricle, I'm going to find the lamina terminalis. Okay? And above, I'm going to find the corpus callosum. And the corpus callosum has some different parts. Let's use this one. Very the sharp one. Now look here. This is the front part of it, and it is referred to this where the bend is. And the bend of it is the genu. The knee, if you are to genuflect, then you are to bend the knee. Yeah. So this is the genu. And then when you pass the genu, there is a section where the corpus callosum becomes very small very quickly. You notice that? Look here. Look. It is coming very small, very acutely. That area where it moves from being very broad and it comes down small, very rapidly. That's the rostrum. And then you come into the lamina terminalis. Lamina terminalis, right? And the lamina terminalis is running in front of the anterior commissure. This anterior commissure joins right side and left side. So we have a big fellow that joins right side and left side, but we also have a little one right here that does the same thing as the anterior commissure. And there's another little one at the back called the posterior commissure. And another one above that called the the what?
What's on the top?
Habencular. H. Habencular. When you said habencular, I didn't get you at all. It's you know the story about the peg and the heat. The H, dropping the H, yes. Habencular. What habencular means? Habenula. Habenula. The string that when the man is riding the horse, he has a string in his hand. He has a rein in his hand. That's the habenula. Alright, so okay. And alright, so what will happen is that we'll be cutting through that, and we'll be cutting through basically in terms of the development of this structure here. What will be happening is that you have this commissure, and then its side here is going to be what? The ventricle, and the lining is going to be the ependyma, right. So in terms of the development of this complex structure, we will have the matrix on the inside here, the matrix on the inside, and then external to that, we will have the mantle cell, the cellular layer. So if I look at this brain, take a look at this. The ideal one to use is one that shows you this ventricle. Alright. Okay, so here we would have the center, the central part, and then outside of this matrix, then we have a cellular portion. So all of these gray matter here is going to represent the kind of cellular portion, or referred to as the mantle, yeah. And then the marginal layer now is going to be represented by white fibers. So you're going from the center where you are within the ventricle. After you leave that, you get outside to the cellular layer, which is the neurons. And then outside of that, now you have your marginal level, your fibers going from here to timber. Well, those fibers are association fibers, or they are commissural fibers, or they are projection fibers. You get it? If they're going from side to side, they are commissural. If they're staying on one side, associating frontal and occipital, for instance, they are association fibers. If they're going downstairs, going down to the spinal cord, they are projection. Easy. You get that? The mantle is really the cellular layer, the neurons. No, the white part is really the marginal. That's the fibers that are leaving. The margin, right? So, in a way, the spinal cord shows it kind of picture very nicely, because in the center of the spinal cord, you will have like your cavity, your central canal. Good. And the lining is going to be the ependyma. Outside of that, now you have your cellular layer with your neuron, your multipolar cells, and so on. And then outside of that, now you have your fibers. Fasciculi, punctate, just gracile, ascending, descending. You get it? The fibers just moving. Alright, okay. Okay. Alright. Oh, now a little bit on the last lobe, which is the limbic lobe. Limbic lobe, yeah. Now, this limbic lobe, some people think the name will change as time goes by. Maybe when you start doing the work, then the name will not be limbic anymore or something else. But that limbic lobe involves this gyrus, which is outside of the corpus callosum. And this gyrus is called the cingulate gyrus, right? And if you follow it around, it comes just outside the genium. Wait, what do we call this back part? Yeah, I didn't remember that I did mention it. Splenium, and then this part going to be the trunk or body, and this is going to be the genium, and where it comes down rapidly is going to be the rostrum, and then we have the lamina terminalis, and this thing here is the anterior concha, and this cavity inside here is the third ventricle. Third ventricle is right in the center. The lateral ventricle is lateral. Okay? The laterals are two, one on each side. So each brain has its lateral ventricle. After all, it's two brains. Two teeth and together, two cavities. And then they'll come together into the fourth, and then, into the third, right? And then the third now is going to run down through the midbrain, to the happy duct, and then get into this one here, which is the fourth ventricle, right? So all of that we can see from this side. Now this gyrus here is the cingulate gyrus, and when you come inferiorly, it is going to end just kind of in front of the lamina terminalis. So what name are we going to give to it here? The paraterminal bone, paraterminal, because it is in the vicinity of the lamina terminalis. And para means beside, or parallel to, close to. So that's a nice name, paraterminalis, right? And in this area, you're going to find the olfactory nerve, olfactory tract, olfactory striae. If you look, I'm just turning on the side right there, and you can see there something related to the olfactory nerve. Olfactory bulb and olfactory tract and striae and all these things. When we do the olfactory, when we do the nerves, in the end we do the nerves, so you get into more detail in that here. But the area is the kind of olfactory area, which is close right here. Between the corpus callosum and the limbic lobe is going to be pericallosal sulcus. And this space here, outside of the cingulate, would be cingulate sulcus. Right. Okay. So pericallosal and cingulate. Yeah. And this cingulate gyrus comes right around, and it splits. See the split in here? And piece of it is going to go up on the medial side towards the surface, right? Helping in forming the cuneus as it were. Not cuneus, precuneus. And then the rest of it is going down on the underside. Let us use this one here, which is kind of, yeah, so it is going to go around here and come right around and end up in the parietal gyrus. The medial one is the parietal. Now listen to me. When you come to the underside of the temporal lobe, what do you call this one out here? What do you call it? Is it on the inferior side or the lateral side? Alright, well this has two names. Two names. So on the lateral side is the inferior. But on the lateral side is the inferior temporal. Okay? But the same one, when you come to the base, you'll call it the lateral occipital temporal gyrus. Same thing. That's another name, but same thing. Alright, so this is going to be the lateral, this one is going to be the medial, and this one is going to be the hippocampal gyrus. And the anterior part of it is bent to give you a prominent reversal as the uncus. And uncus means? Uncus we found in GI, is the pancreas. Uncus, the head. Uncus means hook. Right. So this bent here will give you a hook, right? Yeah. Now this lobe, the limbic lobe, has to do with a lot of learning because the hippocampus is associated with this parahippocampal lobe, this limbic lobe, and it has to do a lot with emotions, a lot of behavior patterns. It has to do with our generating the next, producing the next generation. Alright? Yes. Has to do with sex, emotions, behavior, learning. So that's a very, very important learning. And very important lobe. Because if we were able to produce for another generation, then when we are finished, that's it. The world is finished. Nobody else move on. So the limbic lobe is of significant importance for our life continuation. All right. Any questions?
No, sir.
The limbic lobe. This. All right. You better tell me. So, come find out the limbic lobe. Use this fine language.
Limbic
That's one. Okay, that is specific. What's the name of that one he's pointing? Cingulate gyrus. What do you call the fibers inside it? Singular. Yes, the fibers in this one. So that comes around, and this thing here is the splenium. Show me the splenium, go, right? And the part of the cingulate just behind the splenium, immediately behind posterior. We will call that the retrosplenial section. That retrosplenial section, when you come down inferiorly, is going to be called the isthmus. The isthmus. ISPHMUS. And then the isthmus is going to lead into the parahippocampal gyrus, which is this medial fellow on the other side. So this big fellow here, medial, this is going to be the middle parahippocampal lobe. And buried inside it, then you have the areas of the hippocampus and the amygdala and so on. Yeah. So the limbic lobe, therefore, is the circle. That involves this. Start from here, come down to the area. This hypothalamus. So all your emotions and so on involved inside it. Connective, come around, limbic, come around, retrosplenial, and go back to the parahippocampal lobe with your uncle. And smell, very much intertwined with it. Smell affects us. Smell affects us very much. Smell affects sexuality. That's the reason why when your dog is on eat, the other dog get the smell. What they pick up? The pheromones. Pheromones. Pheromones, right. And those pheromones are picked up and where they stimulate. Pheromones going to the olfactory, the mucosa, picked up by the olfactory nerve, and then they go backwards and link with the hypothalamus. So your FSH, your GNH centers are going to be stimulated. So that's where the sex gets from. Alright? So that's it for today.
Yeah, I'll tell you the computer.